Okay. So before we get started, like I said, this review session is going to look a little bit different because it's less specifics, right, that we have to cover. There's a lot of material. And so I have a couple things prepared for the new stuff, just so that we're all on the same page with that. And then I have a few things that I can go over. But before we get started, are there specific questions about what the exam is going to look like? Any logistical questions that I can answer?
Are we going to be able to use our notes for this last
Yes.
test?
Yep. So
Okay.
handwritten notes will still be allowed.
Okay.
One thing to keep in mind with that though is there's going to be a longer time limit. So you'll have 2 hours for this. There's 65 questions though. And so I'm going to go over a study guide that I've created that I'll send out, but do not focus on etiology or treatment or any of the first 3 lectures that we covered with, what is abnormal versus normal behavior, classification, assessment. Don't focus on any of that. And so
Okay.
while I expect you to reference your notes, right? Don't rely on them because you're not going to get through all of it if you have to look up every single disorder. And so my recommendation would be to make sure you have handwritten notes of the disorders that are a little bit more tricky or ones that you struggle with. And then the other ones, hopefully you can just know from memory, right? That, they're not going to be really specific questions like, you need 5 of these symptoms for this disorder, right? It's more bigger picture, exactly what those what's the disorder activities look like.
Okay.
Other questions? So final is going to be the same as what all exams have been in this class. It'll open Monday at midnight and you'll have all week to take it. Um, I would recommend taking it earlier rather than later, just in case something happens, but I definitely understand that you have other exams and, life things to schedule around, but I definitely recommend not taking it at the last minute if possible. So, especially if there's technical difficulties, right? I mean, that's sometimes inevitable. So, but you'll have all of next week. Part of the reason that I'm allowing that too is because I realize that you have this final paper to do too, and that's due at the beginning of the week. So I want you to be able to finish one thing right and then be able to have enough time to still study. So you can of course do both at the same time, but it's kind of nice to turn that paper in, and then if you need a couple days to study, you can absolutely have those few days. Other questions?
Oh, if we go back through all of the what's the disorder and we haven't sent it to you in previous time, can we still send it to you if there's some of them we're stuck on,
Yep.
or is that time kind of passed up?
Nope, feel free to send it until right before you take the exam. I'm happy to answer those. If you're
Okay.
sending me a lot at once, be patient just because it takes me a little bit to get through all of them, especially if you want specific feedback. But yeah, feel free to send those. That's exactly what they're there for.
Okay. Thank you.
Anything else? Okay, so what I'm going to start with is I'm just going to, if this will allow me, I'm going to share my screen with you all, and so we can go over the study guide quickly together. Let me know when you can see it. Good?
I can see it.
All right, thank you. Okay, so I'll post this later, so this will be available, but this is basically everything that I had just said. Gives kind of the format of what the exam is going to look like. You're still going to use HonorLock. You can use handwritten notes. There's going to be less extra credit on this one. There'll probably be 1 or 2 questions on the actual exam itself. But if you remember, this is the exam that I'm going to apply all research participation hours. If you did that introductory video at the beginning of the semester, all of that extra credit is going to be applied to this exam. So there'll be probably at least 2 extra credit questions on the actual exam, but everything else will just be applied to that. And so as you can see here, I mentioned that you can absolutely use handwritten notes, but just keep in mind, this is 65 questions. They're all vignettes. They all, kind of describe symptom presentation for somebody. And so make sure that you kind of just know big picture with these things. So as I stated here, you don't need to identify specifiers. I'm not looking for that at all. The only thing is if there's going to be subtypes. And on this study guide, I list the disorders with the subtypes that you need to know. And so kind of be on the lookout for that, because the answer choices will have, continuous subtype, selective, if we're talking about dissociative amnesia, things like that. So I will want you to focus on those when relevant. Okay, so again, same protocol as usual. It's through HonorLock. If you have questions with that, let me know. But hopefully by now, after 3 exams, kind of have the hang of it. But this is basically what you need to know. So here for mood disorders, these are all the ones that we covered. Anxiety disorders. So for specific phobia, there's these different subtypes. This is really helpful for differential diagnosis. So we actually use this quite a bit just when we're trying to differentiate, symptom presentations. Being able to figure out what the fear is, right? So if you can figure that out, you really don't even need to know other symptoms for anxiety disorder. So that's one thing to focus on. And like if you're, back up here with mood disorders, there's a lot of criteria for these things. So you don't need to memorize every specific thing. But for things like bipolar 1 and bipolar 2, know that for bipolar 1, you have to have a manic episode. If there isn't a manic episode, it's likely hypomanic, and then that's bipolar 2. Those are 2 really easy things that you can differentiate. So focus on some of those bigger picture things. So then it goes into the OCD and related disorders, trauma and stressor related. All of these we've covered. Dissociative disorders, again, here's another place where there's some subtypes present, specifically for dissociative amnesia. Know generally what those ones are. Somatic symptoms, psychotic, personality. It says here you don't have to know what cluster, right? Sometimes it's helpful if you can differentiate the clusters. Sometimes that's just easier that way if you study in that way, but you don't need to know clusters, but they're split up for you because that's how we kind of conceptualize them, right? It's easier to think of cluster A all together, cluster B all together, and so forth. All right, then sexual disorders. Again, especially with these, because there's so many, just know generally what they are. I'm not going to ask you really specific symptoms for this. I just want you to know what generally this looks like. And these should be pretty fresh because we just covered these. And we had, that short answer portion on the exam too. So just spend some time on these. We're not going to cover all of these exclusively, but just generally know the difference. All right, eating and feeding. Again, some helpful differential diagnosis questions I posed there for you to kind of think about these different things and how you might differentiate these disorders, especially because there's a lot of overlap. And then this week's information that we covered, the developmental disorders, disruptive. Oh wait, that was last week. Sorry, the last week. And then this week's is the addictive, cognitive, and sleep wake. And so these won't be tested. You won't have to know etiology or treatment. And I'm not going to expect you to memorize, especially with substance use disorders. There's 11, 12 criteria for that. You will not need to know that. So just generally know that it has to be substance related, right? You can't have mood. You can't have all of these other things. It has to be due to the substance. And then with cognitive disorders, basically just know the difference between delirium, a major neurocognitive disorder. And then there's quite a few sleep-wake disorders. But again, it's going to be very general. I'm not going to get into a lot of specifics with these because these were the last things that we covered. So questions on the study guide? We're good? Okay. Again, don't get bogged down with all of the specific symptoms. Just try and take a big picture approach. And I'm going to go through some examples so that you get an idea of what I'm looking for. But very quickly, I'm just going to cover just some of the review from this week. And then if you have questions on any of that material, feel free to interrupt or let me know. And then we'll kind of look over examples of what the exam is going to look like. So questions before we move forward.
Since we just got that exam, will we have time to do a little bit of extra credit after that or not? Because there's such a quick turnaround.
What kind of extra credit are you talking about?
Like when you do reaction papers for extra credit, sometimes you've done it for the exams.
Yeah, so this one I'm not going to offer any extra credit because I did have 5 questions on there, which was quite a bit. And so there's going to be a lot more opportunity to apply extra credit to this last exam. So this is
Okay.
kind of just what it is.
Okay.
Question though. Any other questions? Okay, so very quickly, we're just going to go over a little bit of the information from this week's lecture. Okay, so a couple things. So very basic level, just know the difference between delirium and major neurocognitive disorder. So again, delirium occurs really rapidly, right? It comes on very suddenly, it's not gradually, and then symptoms typically fluctuate. So over the course of the day, someone could be okay at one point and then be struggling with some of these impairments later on. And so typically this looks like symptoms of disorientation, kind of not knowing where they are, exactly what time it is, maybe even just difficulty sustaining attention on task. But the important thing is that this pretty much resolves by itself, right? This is typically temporary, whereas major neurocognitive disorder, you can think of things like Alzheimer's, TBI, maybe substance-induced issues, things like that. This is severe, right? This is permanent case of delirium, essentially. So if you can just differentiate it in that regard, it'll be pretty straightforward. And then just know that, especially with neurocognitive disorder, that you have to have 2 points of data, right? So the first is that a family member or the person that's actually experiencing it, or even just the friend, has to report some of these symptoms and that there's these changes in functioning. And then you have to have an assessment done by a neuropsychological assessment, right? So you have to be able to have some data that backs up these impairments. That's at its most basic level. Just know those 2 differences. Okay. Feel free to jump in at any point too if you have questions. So moving on to sleep, I know there's a lot of these. So like I said, just kind of take the big picture approach. So with insomnia disorder, on its most basic level, it's just difficulty sleeping, right? And so this is either difficulty falling asleep at the beginning of the night, or having, experiencing frequent awakenings during the night. Just essentially you can't sleep, right? So there's these different reasons that might be causing that, but you cannot get a full night's sleep. And that's at its most basic level. And that's all I would expect you to know for the exam. Okay. Hypersomnolence disorder. This is when somebody feels extremely tired throughout the day. It looks like insomnia, but they actually get the appropriate amount of sleep, right? So they typically get at least 7 hours, but despite this, they're still feeling really tired. So they have to take a lot of naps. So that's the biggest difference between that disorder and insomnia. Narcolepsy, this is a really interesting disorder, so it might be a little bit easier to identify, but people, like, throughout the day, they just have this urge to fall asleep. And so many times they just pass out, right? Regardless of what they're doing. And so the one thing with this is cataplexy can be at play here. And so that's the loss of muscle tone. And so this could be really minor. Somebody could, just have like muscle weakness in their face, or they might not even be able to move any of their muscles and just kind of physically collapse. I know I'm moving through these quick, so I just want to check in and make sure everybody is still on the same page. Good? Okay. All right. All right, so then obstructive sleep apnea. So the person stops breathing for at least 10 seconds at a time, right? So airflow stops, but there's continued activity in the respiratory system of the brain. And so this could be either, like their airways too narrow, or there's some type of damage or abnormality that typically is causing this impairment. But that's kind of the biggest thing with that. And so again, this person typically snores. And then this type of sleep apnea specifically is often found in individuals who are overweight. Central sleep apnea. So this is when the person is experiencing a disruption and halt in airflow again, but specifically at least 5 per hour of sleep. So that's a really important thing. And so one other thing to differentiate this from obstructive sleep apnea is that there's complete cessation of respiratory activity in the brain. So it stops entirely. Whereas obstructive, that still is happening. It's just the airflow is impacted. And so basically the person stops breathing because the brain isn't telling them to breathe. And so that this is typically found when, more like disorders related to central nervous system or vascular disease. But just know that that's the biggest difference between central and obstructive. Okay, sleep related hypoventilation. So the individual continues breathing, but there's actually episodes of shallow breathing that are associated with carbon dioxide levels. That's the key for this one, that they're not getting enough oxygen. If you see that anywhere in the question, that's going to be this specific disorder. Okay, and the non-rapid eye movement sleep arousal disorder. So this is typically observed in children. So that's one thing that you can look for in the question, is that it's oftentimes in kids. And so this is when, the kid's waking up at the night, but they're not fully waking up. And so they're not getting that conscious alert arousal. And so typically what happens is they either engage in sleepwalking behavior or they have sleep terrors. And so those are two things that you can look for this disorder. And then finally, nightmare disorder. And so this is exactly what it sounds like, right? This occurs when someone repeatedly wakes up at night because of a detailed, frightening nightmare. And so it's probably not going to get this specific, but just a reminder that this occurs in the second half of the sleep period, where they're more likely to be in REM sleep. So we only have these really vivid dreams in REM sleep. So that's one thing you can look for too. All right, so then finally with addictive disorders, so all substance use disorders have the same criteria. They just depend on whatever substance that the individual is using. And so the name of the specific diagnosis only depends on what substance they're using and experiencing problems from. All the other criteria will be the same. And again, there's a lot of criteria with this, but just some things to look for, things like craving, tolerance, withdrawal, excessive time planning and trying to get the substance. As long as it's centered around any type of substance, then that's what you can focus on. The one thing that you'll be able to identify that's a little bit different is gambling disorder. And that will be a lot more straightforward. You should be able to figure that one out. So, okay, that was a very quick version of this week's information, but does anybody have questions or need clarification on anything? We're good? Okay, so these things will be on the exam, but again, there's going to be information from the entire semester on it too. So just make sure you don't forget about this week's information. Okay, so the other thing that I was going to do is more of an activity where Zoom apparently has specific rules and they won't let me do this. I was going to create some polls so that I could post a question and you guys could vote what the right answer is, but the questions are too long, so Zoom won't let me do that. So we have two options with what we can do here. I will share my screen again, and I have 10 questions. We don't have to go through them all, but what we can do is I can give you time to figure out what the answer for a couple of them, and then we can review it, or we can do them one at a time. Does anybody have a preference?
One at a time.
One at a time? Okay.
Yeah.
Perfect. So what I'm going to do then is I'm going to share my screen. I'm going to show you the very first question. I'm going to give you a few minutes to read it. And then whenever you're done, either in the chat or if you want to yell it out, give me an answer. I don't care if it's right, wrong, whatever. Don't even reference notes. Just kind of test yourself in this regard. And then we'll talk about what the correct answer is. And so with these two, I know this is scary. There's no pressure with this, but with these two, a couple of them might even be on the exam. So pay attention to these. Take notes if you want to, but this is exactly what the exam is going to look like. So this will be a really good practice. All right, are you ready? Okay, let me just get my screen ready. Okay, and if you have trouble seeing it or need me to do anything, please yell out at me. Let me know when you can see it. Okay, take your time reading this then.
I think it would be A.
Okay. Do people need more time on this one? Okay, so I'm gonna stop sharing my screen quick. So if everybody could just either yell out what they think or put it in the chat so we can talk about it. Okay. So I've got a couple A's. Does anybody disagree? Why do we think it's A?
I guess I'll go first. There's some background traffic.
Okay. Okay, so A is right. So it's dissociative amnesia, continuous type. So if you remember, continuous means cannot recall events from a particular date up to and including the present time. Whereas selective is they forget some, but not all of what happened during a given time. And then the last two, so DID, that's, you're switching identity. So that's not necessarily related to this. And then depersonalization or derealization, so that, depersonalization, you're detached from your body, your mental process, right? Whereas derealization is you're detached from your surroundings. So the best possible answer for this is dissociative amnesia, continuous type. Does that all make sense to everybody? Okay, this is exactly what questions are going to look like. So some are going to be really short, some are going to be really straightforward, some might take a little bit, but I wanted to give you an example because this will be one where you're going to need to know the subtypes of dissociative amnesia. So let's get going with the next one then. We'll kind of follow the same format then too. Feel free to yell it or put it in the chat. Let me just scroll down. Okay, here's the second one.
A.
A, okay.
Just kidding. I changed my mind to B.
Okay. All right, we'll do one more minute and then I'll stop sharing. Okay. All right, looks like we got a lot of Bs. Does anybody not think it's B? For those who do think it's B, what made you pick that versus like major depressive disorder?
The time frame.
Okay, what exactly about it?
Because it was for 4 years. It never changed.
Yep, that is spot on. So with major depressive disorder, they have to have a major depressive episode, right? And so that is typically 2 weeks long. And so they have to have at least one episode and never experience like a hypomanic or manic episode in the past year. Whereas with persistent depressive disorder, this must last for at least 2 years, right? So this is typically, you know, a longer and less severe version of major depressive disorder. You're constantly just feeling pretty down. And so you cannot go longer without 2 months without experiencing any type of depressive symptoms. So this was a really, really good job with that. This one is where you want to know kind of like the time criterion, because otherwise a lot of the symptoms between major depressive disorder and persistent depressive disorder are identical, right? So really good catch with that. And then the last two, you know, insomnia, that's specifically for sleep. And so cyclothymic, that's a bipolar disorder, right? So that is a milder version of bipolar 2, but it's combined with the time duration of persistent depressive disorder. And so that one was just kind of thrown in there as another option. But yeah, really good job with that. Pay attention to the no disorder too. So on the exam, I'm going to give you some hints. I think there's 5 maybe. So not all of these things are going to be pathological, right? So make sure they actually meet criterion and try not to push them in, because there will be some answers that are truly no disorder. And so just pay attention to that too. Okay, nice job. We'll move on to the next one. Or we'll do one more minute for this one. All right, let's see what everyone was saying. So we have D and A look like the most popular choices. Does anybody want to jump in?
I say D because she tends to want the attention all on her. If it's not directed towards her, that's when she acts out. And then immediately once it's back on her, she tends to go back to being this friendly person that everyone knows about. So that's why I said D.
Okay. Anybody else?
I said D just because the fact that she immediately makes these friendships, whether she knows them very much or at all, like an instant friendship.
Yeah, so personality disorders are tricky, right? Because we tend to view them more dimensionally anyway, because there's a lot of overlap in symptoms. And this was a really, really convoluted question. But the key was, and it sounds like most of you picked up on this, was being the center of attention. And there's only one disorder that is surrounded by that, and that's histrionic personality disorder. They're attention seeking. That's the whole point of that disorder. And so I know there was a lot of extra information with that, but that alone tells you all you pretty much need to know with this. And so they basically do anything that, they need to do to get that attention. And so this can look like, dressing provocatively, or being sexual in a certain way. Like they can do anything, right, just to get that attention. Whereas with some of these other disorders, like narcissistic, they view themselves as really important. So oftentimes they try to be the center of attention, but that's not the key focus, right? They need an admiration from others because they view themselves as extremely important. And so those two can get a little bit tricky, but that's kind of the biggest piece to differentiate them. And then again, dependent, they need to be cared for by other people. They have a fear of that separation or abandonment. And then borderline, this is a host of a lot of symptoms, right? They can't maintain interpersonal relationships. They have unstable mood and thoughts about their self-image. They're really impulsive. And so truly the only one that fits here is histrionic. Does that make sense to everybody? Okay, nice job. All right, we will move on. Here's the next one.
B.
B, okay. All right, one more minute. Okay, let's see. So we had one B. Looks like pretty consistently B. Anybody want to throw out why they picked that?
I thought B mostly fit because she's ultimately restricting her intake, in addition to compensatory behaviors. While she might break that train twice a week, she's restricting most of the time, and she's severely.
Anybody else?
Low weight implies anorexia, and then it identified purging and binging in the statement.
Yeah, I mean, you both made some good points, right? The key with that is low weight. So we can already rule out some of the other disorders. If it's low weight, it's likely down to two of them, right? So RFED and anorexia are both low weight. Does anybody know the difference between those two, how you differentiate low weight?
Isn't the RFID the one where it's malnutrition? There's not enough food available. Isn't that?
Yeah, pretty much. It's essentially being a really picky eater, right? There's no fear of gaining weight, and they're not basing their self-evaluation on weight. It is simply they just don't like food. They maybe had a bad experience with like choking, or they're just a really picky eater and they don't get the nutrition that they need. And so RFID individuals often are low weight as well. But the difference is with anorexia, they're deathly afraid of being, overweight, or they have this really distorted view of themselves. And so we can eliminate the other ones, right? We knew it was at least had to be anorexia or RFID. And then the key with that too was there was some evidence that she engages in some compensatory behaviors, right? And so if that exists, then that automatically means that that is purging, binge eating, purging type. So it couldn't be bulimia, right? Because oftentimes they're not necessarily low weight. They're typically pretty average. And then body dysmorphic disorders, just, because they are preoccupied with a defect, in appearance, right? And so that's not necessarily related to weight. That could be like a mole or like their nose, things like that. It's not necessarily tied to that weight. So really good. Yeah, no compensatory behaviors. Really good catch with that. Does that make sense to everybody? Okay. All right. Okay, here's the next one. All right, we'll do one more minute with this one. I know we're going through them quick, but you'll have more time on the exam, hopefully. right, let's see what everybody was saying. So we have B and A were the two most common, which are probably the two trickiest, right? Does anybody want to think or throw out something that maybe had them lean one way or the other? And again, these are really hard. I recognize that, especially with bipolar disorder. So don't feel like you need to have this right.
I chose bipolar 1 because it sounds like he's manic.
Anybody that picked bipolar 2 want to say why they thought it was bipolar 2? Okay, that's okay. We'll go through it. So, wait, let me see real quick here. Okay, that's a big one. No hospitalization. So the really tricky thing with bipolar 1 and bipolar 2 is sometimes mania and hypomania can look pretty similar. There's some symptoms that overlap. However, with specific mania, there's significant impairment. There's either psychotic symptoms or there's hospitalization. So those are big things to look for. And we don't have any evidence of that here. Yes, we have elevated mood, goal driven, right? Those are things that are associated with mania, but they can also be associated with hypomania. And so the thing here is we can't tell really one way or another. There's kind of a lack of information there. But if we were just basing it on hypomania or mania, we'd probably lean towards hypomania. But the thing that separates it is this major depressive disorder, right? He meets criteria for that. And for bipolar 2, you must have had at least one major depressive episode. Whereas in bipolar 1, you don't need that. So the fact that he had that in combination with some of these symptoms that look like hypomania and aren't as severe as mania, bipolar 2 would be the best option here. So I know that's really tricky. Does that make sense to everybody? Okay. This one was specifically worded to be confusing. It's probably going to be a lot more straightforward on the exam with this is clear evidence of mania, right? So that's the biggest thing to differentiate those two. Okay. And again, disruptive mood, again, that's not even really related to this. This is just when kids get really angry, right, and have these temper outbursts. And cyclothymic is a milder version of bipolar 2, but the thing is they must never meet criteria for a hypomanic episode. And it's pretty clear at least hypomania is going on here. And so you can rule that out as well. Okay, feel okay about that one? Okay, we'll do the next one. Thanks for bearing with me with this format. I have done polls and a lot of other classes and reviews, and apparently Zoom just did not like the length of my questions. So thanks for bearing with me with this. Do about 1 more minute on this one if you want to throw in a guess. All right, let's see what our answers are here. So we have E and C. People want to jump in with this one? What stood out?
Underweight, that he wanted compensation and that was his purpose for faking the disease.
Okay. Anybody else? Why did some people put no disorder?
Well, it doesn't really talk about like the fictitious, isn't that more of making it up? And they didn't say what he was making up. He was just saying that he had pain and it's not somatic. And isn't the Munchausen proxy, that's not the fictitious one, is it?
Yeah, so that's fictitious is now called that. So Munchausen and Munchausen by proxy, it was replaced with
And that-
factitious disorder.
And that's not it either.
So this one's really tricky, right? Because it seems like it could maybe go one way or another. But the thing is, we don't have a lot of information here. And so if we just simply break this down, we see a veteran, right? He's coming back with physical pain, which is likely true, seeking VA benefits, which they're entitled to. However, there's no cause for pain, right? And so this is where it gets really tricky, is that they can't identify a cause and they assume that he's faking it to get these benefits, right? But the thing is, he doesn't have a disorder. And so, like you had mentioned, the thing is with somatic symptom disorder, you're experiencing these symptoms and you're believing you're experiencing these symptoms, but there's no medical cause. But the thing with that is you have to focus on disproportionate thoughts about the illness, right? Like you have to be obsessed with these thoughts, and that's pretty much all consuming. We don't have evidence of that. And then with factitious disorder and factitious disorder by proxy, you're faking the symptoms, right? But the purpose is to gain attention by others. There is no evidence that that's exactly what he's doing here. And so this basically just says that, he is experiencing these symptoms. They can't find a cause, but he just wants some benefits from that. And so there's just not enough evidence to suggest otherwise here. Does that make sense? This one was hard. Okay. So even though it might look like an actual disorder, make sure that it's meeting that criteria, right? Just make sure that it's meeting some of those big things. Otherwise, there's no evidence of that. That's when we start to, pathologize normal behavior. All right.
Disease or illness.
What was that?
I think that I was gonna say that I think the one thing that helps me to remember these, because I remember that I got a similar question wrong when I sent in a what's disorder for this.
Sure.
Is there factitious wants the attention, that's their desire, whereas if you're just faking it with no disorder, then then money is the purpose. If money's the purpose, then there's not really a disorder. If money's not the purpose, but maybe attention or just wants to seem important, then that's a disorder.
Yeah, exactly. I mean, go back. These are all very confusing, right? Because sometimes they are actually experiencing symptoms and there's no identifiable cause. And other times they're truly faking it. And so just being able to figure out what the goal is, what the intention is, that can help you differentiate these. Okay, we'll move on to the next one. know this one is long, but if you want to throw in a guess, we'll do 1 more minute on this one. Okay, looks like we have a pretty unanimous decision with B. Does anybody want to throw out why they chose B?
For me, it was because it was co-occurring with the bipolar.
Okay,
It had
Look-
those episodes with that.
so the mood symptoms is what you're talking about.
Yeah.
Okay.
Mhm.
Anybody else? That's spot on. I mean, you can rule out, there was a lot of information in that, but you saw evidence of delusions and mood. And so immediately that means that's schizoaffective disorder, because essentially you have to have psychotic symptoms as part of the mood disorder, right? So they would not be there if there wasn't also disturbed mood. Whereas with schizophrenia, you're basically just looking at all of these other psychotic symptoms, so delusions, hallucinations, disorganized speech, right? And there's time frames with that, but there's no evidence of mood. So if you throw in mood at the same time as psychotic symptoms, then that means it has to be schizoaffective disorder. And so again, it won't be briefed psychotic disorder because that's basically a short and less severe version of schizophrenia. And schizotypal is a personality disorder, right? That's kind of extremely odd and bizarre behavior, but they recognize maybe when delusions aren't true. So that's how you can tell with schizoaffective disorders that mood piece is so huge. And I think even, let me pull up the question. Even in the question, it talks about how 2 weeks passed with no elevated mood present, but the psychotic symptoms remained, right? So that's your evidence right there. Okay, good job with that. So I do have a couple more. I want to be aware of time and I don't want to keep anybody too long. So if you want to stay, we can go through a couple more. If you want to be done, we can absolutely be done. So just kind of let me know where you're all at right now.
I'm good to go a couple more.
All right, feel free to leave, if you want. I recognize that we've already gone an hour, so I don't want to take up too much of your time, but we'll go. I only have a couple more if you want to stick around. So we'll get started with the next one.
Can we assume that he's younger in this question?
Good question. Yeah, so it's talking about parents, right? So you can assume he's under the age of 18. Which is a key thing to differentiate these disorders. Okay, we'll do 1 more minute on this one. All right. Let's see. We have D pretty much exclusively. Why is it D?
The age was a big factor for me with him being so young, plus his aggression in multiple situations and cruelty and destruction.
Yeah, exactly. Because if he was over the age of 18, right, it's probably antisocial personality, or you'd have to rule that out first. But since he's under, it's likely either conduct, ODD, or intermittent. And ODD is more where it's just angry or irritable mood, right? You're pretty defiant, you're vindictive. Whereas with conduct disorder, that's the kid-friendly version of ASPD. That involves violations of rights and rules of society, right? So it's basically demonstrating all of those areas. And so really good eye catching that age differentiation, because that's how we would differentiate these. So that's the biggest thing to look for in that one. Does that make sense to everybody? Cool. All right, do the next one. So I've just got 10, so I have 2 more, this one and 1 more. We'll do a couple more minutes for this one. Okay, let's see. So we have A, it looks like most people put that. What stood out in that question?
Pain during vaginal penetration.
Yeah, that's pretty much it, right? I mean, there's nothing that indicates there's a lack of sexual desire, right? So we can't say that it's a female sexual interest or arousal disorder. We can immediately rule that one out. And then it says nothing about orgasm, so we can rule that one out. It's just simply pain, right? So there probably is sexual desire, but there's a lot of pain associated with it. So this one hopefully was a little bit more straightforward, because you didn't have to figure out if it was arousal or desire or any of those stages, right? It's just simply pain. So good catch with that one. Does that make sense? All right. Got 1 more. Okay, we'll do about 1 more minute for this one. All right. So we've got C pretty consistently, or B. What do people think?
Well, at first it tricked me up because it said unsuspecting,
Mhm.
and that's not the voyeuristic. It's because he is exposing himself to everybody to, so that's, I had to go back and I had to think about that anyway.
Yeah, they can be a little bit tricky, right? Especially because some of them, they look a little bit the same, right? There's some symptom overlap potentially there. And so the correct answer is exhibitionistic, right? So this is exposing genitals to an unsuspecting person. And so that's just its most basic form. Whereas a fetish, we've talked about that a lot before, especially in the previous exam. You are aroused by non-living objects. Voyeur, this can be a little bit tricky too, but this is observing an unsuspecting person, right? So they're either naked or in the process of disrobing. And then frotteuristic, so this is rubbing against someone else. So the two that you got confused between are ones that look alike, but the key was either, let's see here. Yeah, so the key was either observing, right, an unsuspecting person, or exposing. And so they're the exact opposite in that regard, but that's about the level that you would need to know to differentiate them. Does that make sense to everybody? Okay. So that's everything. That's all the examples that I had, but this is exactly what the exam is going to look like. And so it's going to be 65 questions again. Some will be pretty short, some will be longer. It'll all be multiple choice. You won't have any short answer. Some of my colleagues do fill in the blank for these. So if you're anything like me, at least seeing the answer choices helps me figure out which one's right. And so hopefully you won't have to spend as much time on it that way. And so you can eliminate some really quickly, and there'll be more specific examples on the exam with what to expect regarding the no disorder ones. And so anytime you have questions, feel free to reach out. Let me know if anything comes up, but this is generally what the format's going to look like. Does anybody have any last minute questions? Okay.
I have a
Yeah.
So I get really thrown off when it's not called impairment. Does it mean that it still can be diagnosed even if it doesn't cause impairment
It
or
depends on,
distress?
are you talking about specific disorders or just in general?
Just all of them. Yeah.
So a lot of them require distress and impairment. So there's only a few that don't. And so the criteria for that will be really, really specific. And so that's going to be some of these sexual disorders, right? Because they don't necessarily have to be impaired themselves. They have to be violating others. And so it's going to be really clear in the question whether or not I am trying to get you to figure out if that impairment is a key piece. That's likely not going to be the thing that you need to focus on, because generally most of these disorders are impairing or cause some type of disruptions in functioning. So I would be less worried about that.
Okay. Thank you.
Yeah. Anything else? Okay. Well, I'll post this link again tonight. So if you need to come back to it, feel free to watch it again. I'll post the study guide. And then again, the exam will be made available Monday. You'll have all week. Feel free to email me questions, do the what's the disorder activity, and just let me know if you need anything, okay?
Are we allowed to print off that study guide and take extra notes on it?
Sure. Yep, that's fine.
All right.
As long as
Thank
it's
you.
not all typed up, right? So you can print the study guide, but just write on the study guide.
Okay. Perfect. Thanks.
All right. Have a good rest of your week, everybody, and we'll talk to you later.
Thank you.
You're welcome.